our first new Global Health Matters live for 2021. This is a series, and my name is Noor. I'm the finance officer with Irish Global Health Network. I'm actually stepping in for Hala Ali, the coordinator for Esther Island and Esther Alliance under the Global Health Partnership. Please be reminded that after this event, we'll be moving. Hold on a second, the thing is. We'll be moving this event to last Friday of every month at 1 p.m. Irish time. We'll be also hosting this expert to discuss the most topical and pressing issues in global health. So today's topic is global inequity in COVID-19 vaccine. A recording of this webinar will be available on our website and also our YouTube channel. As shown in the chat, Irish Global Health Network and also Esther Alliance for Global Health Partnership. The live streaming is also available right now. As you can see, we are recording and we are sharing it live on the YouTube channel, Irish Global Health Network. If you have any question during the webinar, please use the question and answer features at the bottom of the screen. And also for now, I will leave you with my co-host, Nadine Ferris France, the Executive Director of Irish Global Health Network. Welcome, everybody.
Thanks, Noor, and welcome everybody. Really excited to be kicking off our new series, Global Health Matters, and today particularly delighted to be co-hosting this first in the series with Access to Medicines Ireland, with Concern, with Oxfam, and with SafetyNet. So welcome everybody. The topic of today, it's in the media all the time. It's in all of us are working on it, I would say almost daily at this point. There's been a lot of positive movement in terms of the rollout of vaccines, particularly for wealthy countries in the past number of weeks. But today what we want to focus on is the landscape worldwide, and we want to look at the inequity that we are witnessing on the issue of vaccines, COVID vaccines. We know that last week there was a landmark report which was released by the Joint Oireachtas Committee on Foreign Affairs and Defence. And I'm delighted that we may be joined by some Irish politicians later on in the session, and we'd love to hear from them if that's possible. We're also delighted that today our theme in the Irish Global Health Network for 2021 is equity. So we'll be doing we'll have a lot of focus on equity. So today we have some wonderful speakers, 4 really, really knowledgeable speakers with us. We're delighted to introduce them. So first we have Dr. Ashling McMahon. She is an assistant professor at law at Maynooth University, and she specialises in medical and intellectual property law. And her work is particularly focused on the role of patients within the health context, including the impact patents can have on access to and delivery of healthcare. So welcome, Ashling. She's also a very strong member of the Access to Medicines Ireland campaign. We're also joined all the way from Kenya by Peter Kamalingan, and he's the Pan-African Program Director for Oxfam International. He's Ugandan and he has over 20 years experience in social justice struggles, in development policy analysis, in humanitarian planning and conflict management. He's also a practicing farmer in eastern Uganda. And I love, Peter, that we already know about you, that one of your pastimes is keeping bees. So great to know that about you. Welcome, Peter. We're also joined by Dr. Fiona O'Reilly. Fiona is the CEO of SafetyNet Primary Care. Fiona has devoted her career over the past 3 decades to working in the area of healthcare, both nationally and internationally, particularly with a focus and her passion for achieving health equity for all and bringing humanitarianism home. At the moment in SafetyNet, Fiona has been working with her team tirelessly to protect the health of marginalised groups, and particularly those living in congregated settings here in Ireland. So welcome, Fiona. And then last and by no means least, well known to many, is Breda Gahan from Concern. She's a registered general nurse and midwife in Ireland. She's been working for over 30 years on health and HIV in various countries, including Iraq and Sudan and Cambodia and Mozambique. And she began working as a nurse here in James's Hospital, and she's currently the Senior Health and HIV Advisor to Concern Worldwide. So welcome all of you. And I think we'll kick off, if we can. Ashling, we might come to you to help us frame the issue of just vaccines and inequity. You know, there's growing and significant concerns around the lack of global equitable access. Can you tell us more, just to help us set the scene, in terms of what are some of the key issues that we should be aware of that we're currently facing?
Sure, absolutely. So first of all, I suppose it's fantastic news. Now we're, over a year into the pandemic, but we have vaccines and vaccines that have been approved for use. And I think when we saw that, people were, really hopeful. I think it does bring much hope, and that's the first thing to say. However, there's a significant amount of inequity involving how vaccines are being distributed, as many of us are familiar. Some of the recent statistics, the People's Vaccine Alliance has reported that 9 in 10 people in over or up to 70 lower income countries worldwide will not have any access to vaccines in 2021, and that it will take to at least 22 or 23 for many people in many countries to have access. Meanwhile, we've also seen, I think, 16% of the world's population, mostly in higher income countries, have access to over 60% of the vaccines that are currently being produced, or at least the expected agreements for those vaccines. And we've also seen issues around vaccine access in higher income countries, but there's significant issues in low and middle income countries. And this has led people like Dr. Tedros Ghebreyesus of the World Health Organization to say that we really are on the brink of a moral catastrophe. And I think that is something that we can't take lightly. We really need to move to address this. And the other reason that I would just emphasise, and Access to Medicines Ireland has been working, and indeed other groups, on these issues. It is about social justice, it's about equity, but it's not just about equity, it's also pragmatism. If we want to bring COVID-19 under control everywhere, all over the world, which of course all of us want to see that happening as soon as possible, we really need to have vaccines that are rolled out to everyone, because without vaccines being rolled out, you have the risks of the virus re-emerging in areas that it was brought under control due to travel. And you also have the risks of new variants, and we've seen these in the past. I'm sure others will speak about this. Recently, we've seen new variants, and those new variants in future could be resistant to the vaccines we have. So really, both for social justice reasons, but also for the kind of broader pragmatic reasons, we need to have global equitable access to vaccines as soon as possible. But unfortunately, there is an artificial scarcity that is being created and maintained, and there really are things that pharmaceutical companies could be doing to address this, which we need to see happening, and governments as well trying to support those.
Ashling, can you say a little bit more about this, the issue of artificial scarcity? I think it's something we're all very interested in, and I know there's kind of layers of complexity. So could you say a little bit more about that?
Yeah, absolutely. So one of the things that at the start of the pandemic, many people were very fearful of, including within the IP and the health communities, and also obviously NGOs, were worried that we would see some of the mistakes in the past happening again. And by that, I mean, so for within the HIV/AIDS crisis is an example of this. For many years, there was antiretroviral drugs which would have been available, but many people in many countries, particularly in sub-Saharan Africa and other developing countries, simply could not access these medicines. And one of the issues, one of the reasons for that, not the only reason, but one of a key contributor to that, was the way in which pharmaceutical companies were actually using their intellectual property rights. And just to say something on this, just for those that may not be as familiar with IP, an intellectual property right, including a patent, for example, what it does is it gives somebody the right to stop others basically using your invention, which could be a medicine, it could be part of a vaccine, it could be a diagnostic test, and you have that right for a period of 20 years once you get it. So what that can do in practical terms is it means that a pharmaceutical company could potentially stop others using their invention. Their permission would be needed in order to license the medicine. And if they fail to do that, if they don't give that permission, then it's very difficult. You can't produce a generic drug because you'd be in breach of intellectual property rights. And in the HIV/AIDS crisis, we saw this playing out, and we saw huge petitions from NGOs in order to get that access, get it delivered, and eventually that was negotiated and delivered in time, but millions of lives were lost in the meantime. Moving on to the COVID-19 crisis, we've also sadly seen issues. So, for example, remdesivir, which was a drug during the summer that was thought to be very promising in treating COVID-19. And subsequently, some of the studies suggested otherwise. But at the time, when it was thought to be promising, it was a promising drug, people were suffering in hospitals, the intellectual property holder, Gilead, did not agreed to give much of its manufacturing capacity or much of its supplies to the US in that time. Up to 100% of its supplies in July was going to the US. And that meant that there could potentially, and there was, shortages elsewhere. In the vaccine context, we've seen companies agreed to supply mostly higher income countries, it has to be said, with vaccines, and they're kind of going on the basis of negotiated deals rather than necessarily who is most in need. There's an artificial scarcity, and that scarcity could be addressed by getting companies to share not just intellectual property, they must share IP, but also data, know-how, and basically to facilitate other companies making vaccines so that you'd have more people making vaccines, and the more people you have, it makes sense, the more vaccines you will have for everyone.
You know, and just in terms of how to do that, you know, I know you've been really very involved and very successful, as we mentioned, with the joint report that came out last week with the Erectus. Can you say something about the mechanisms, about CTAP, about COVAX, and about, you know, in general, what are some of the current proposals that could really help us address not just equitable access, but also pragmatism, you know, I love what you said, vaccine pragmatism.
Yeah, so there have been, and since it has to be said, the World Health Organization and other groups have been working on getting these mechanisms off the ground to try and kind of address the problems that were foreseen, and sadly the problems that have occurred. COVAX, just to say something on that, first of all, it's a system whereby the World Health Organization backs this system, and it's to facilitate access to vaccines in many countries, in particular in countries, low and middle income countries. And it does do that. However, there is an issue with COVAX. COVAX target is to provide 20% of those populations. Now, it is providing vaccines on the ground, but 20% of coverage to populations is simply not enough to have, you know, vaccinations for everyone in those countries. So COVAX is, in my view, a short-term measure. It is important, and it is important that it is supported to provide some vaccines on the ground. But in terms of long-term equity, we really need to be going beyond systems of donation. We need to also be actually upscaling manufacturing capacity. We need to have more vaccine manufacturers supplying vaccines for countries, and we need to facilitate that. And the best way to facilitate that, in my view, is through the CTAP system. And the CTAP system is another system the WHO has set up alongside COVAX. It's complementary to COVAX, and indeed, basically, it could address some of these global equitable issues in terms of vaccine access. What CTAP does is it's a proposal to share intellectual property, data, know-how, knowledge. It's basically a one-stop shop that's supposed to facilitate companies who are willing to voluntarily license their intellectual property, their data, their know-how, coming together in the spirit of solidarity to end the pandemic, or at least to bring it under control, which I think is very important to say, because this is in everybody's interests. Those companies are encouraged to do that, and countries are encouraged to support it, and so to facilitate this. And as you mentioned, the Orectus committee issued a report last week, Access to Medicines Ireland. We spoke before the committee in February alongside David Navarro of the World Health Organization, and also Winnie Benanini of UNAIDS. And the committee's report was really important because it actually endorsed, it first of all highlighted the global inequity and accepted those issues, and highlighted the need for recommendations on this. And it recommended that the Irish government would formally endorse CTAP. That was one of its key recommendations. And we are very hopeful that the Irish government would do that, but that it would also advocate for CTAP at a global international level, both in the EU and also the UN Security Council, because it needs more support in order to facilitate it. And the other system I would like just to briefly mention is also the TRIPS waiver. So CTAP is a voluntary system. Voluntarily, companies are encouraged to share their IP. However, if those voluntary systems do not work, then I think we have to be seriously considering mandatory measures. And a mandatory measure would mean that companies are effectively forced. We're saying that intellectual property rights would be suspended for the duration of the pandemic or another time frame. And that is what the TRIPS waiver is suggesting. It was a waiver put forward which would waive or suspend IP rights for a period of time temporarily during the pandemic in order to facilitate access. And it was put forward by India and South Africa, and other countries have also joined that since. The difficulty is there's a significant amount of opposition to it from mostly higher income countries at the moment. And in the absence of voluntary licensing and voluntary deals and companies, you know, engaging with CTAP, I do think, given the significant issues we're facing, we need also to be considering the TRIPS waiver and the proposal, and alongside this, encouraging companies or forcing companies to share their know-how, to share the knowledge, so that more and more companies can make these vaccines to address these problems for everyone's sake.
Thank you, Ashling. And I see in the chat a number of the resources that you were speaking about are posted there in the chat, so people can follow up on that. So Ashling, I think what we'll do is we'll leave it there. I'm going to go over to Peter, and then we'll come back around to you in the conversation, and encouraging everybody who's here, if you have questions for any of the panelists or comments that you want to make, please post them in the chat, and we'll try and get to them. So Peter, just in your position, so you're at the moment, you said you're in Nairobi today. I mean, you hear what Ashling is talking about there in terms of, there's a groundswell here working on CTAP and COVAX. We know that the first, vaccines arrived through the COVAX facility to certain countries in Africa just recently. What's the perspective? What is your perspective on that? What do you think that, what are some of the issues there, and what do you think we should be doing about it?
Thank you very much, Nadine, and thanks for Aisling as well for setting the frame. And I think that he has highlighted quite a number of issues on the dynamics that are happening around the COVAX. I think maybe what I wanted to start is that sitting here in Africa, these issues of COVAX are still distant things. We're in the receiving end of the goodness of whoever comes to rescue the continent. So I think that it's not a very comfortable place, especially if you know what this pandemic has meant and might continue to mean for people. I think it's important to underscore the fact that the COVID did not cause things, but I think it revealed more the inequalities that are already pre-existing. And I think that many agencies, including Oxfam, have been speaking about the dangers of this extreme inequality, that if it is not reduced, in the end, I think everybody loses, even though it might look like the stronger win for now. Now, coming to your question, Nadine, I think that first, there is the COVAX facility that is being organized in the way that Ashling, I think, has described. From Africa, we welcome these charitable doses of vaccines, which have been organized through COVAX. And for those who are getting the vaccines, the very few who are getting vaccines, I think it's making a difference for their lives and their hopes and their dreams. But let's be clear that it is not nearly enough, and it will take much longer to address the huge needs. Within time, we have to bring the disease under control. An example is that vaccination in Africa was planned to start, I think, at around the same time with the rest of the world, as it did in Europe as well. But the first doses only arrived more than 2 months later. I think, as Aisling has said, it was targeted to reach 20% of the population probably by now. But as far as I can see, I think the latest figures we have is that no country has received enough to vaccinate even 1% of our population in the continent. And there are simply not enough vaccines to go around the world, as I said. And our own estimation is that probably at best, we may only be able to vaccinate 1 in 10 people by the end of this year. So I think that our strong issue is that this is not something that is going to be addressed by charity. Far from it. I think what is important is that the recipes and the technology and the science of producing these vaccines, given the circumstances, the extraordinary circumstances that the pandemic has presented, and the suspension of patents, I think that's where our energy should be. That is the most urgent thing that needs to be done at the moment, so that we can scale up production of the vaccines to meet the huge needs. And it's important to know that many countries, including in the developing countries like South Africa, do have capacity to actually mass produce quickly enough vaccines, if only we can temporarily waive those trips, as we were saying, and then most importantly, share the technology to meet an urgent humanitarian need. And we know that the WHO rules provide for this. So it's a question of just strong global will to address a big global problem. And I think that to think that this should be something that should rely on the goodness and the charitable gesture, which is appreciated, but the extraordinary circumstances that the pandemic has presented requires that I think we become more decisive, become more human, and build on global solidarity that is most needed at the moment. And I think that it is important that countries like Ireland, I think, the good Republic of Ireland, should be able to support this within the WTO. And also things like the EU instituting vaccine export controls at this time when we need global solidarity. I think that is not something that should be called out.
Yeah, thank you, Peter. Some really, really important points there, and really just, you know, touching on what really just dovetailing what Ashling is saying about the focus on CTAP and all of us just coming together around those issues of manufacturing and supply. Peter, I just wonder, in terms of, you know, the issues around vaccine hesitancy, what have you, you know, what have you seen so far? What are you thinking in terms of, you know, how is that going to be a big issue? What are you thinking in terms of addressing that? I know these are questions we're asking. We're asking in Ireland the same thing. You know, hesitancy, people who are, you know, maybe not so sure about the vaccine, you know, for all sorts of reasons.
Yeah, that's true. This morning I was talking with a colleague. We were in a call with a colleague in Nigeria, and she was reporting that there's a lot of hesitancy, I think, in the continent, particularly because I think most of Africa has received the AstraZeneca vaccine. And I think that globally, that is also something that has raised quite a lot of concerns when we hear that a couple of countries in the EU countries have, and a couple of others have paused the rollout of this vaccine. I think that is important, but that's also an area that needs to be reinforced with more openness, more transparency around these issues. And I think that people are hesitant because the experience of this big pharma that is largely informed by profit motivations also creates suspicion. So I think that to build global solidarity and to build confidence requires that we have more openness, more transparency, so that we can be able to increase the confidence about these vaccines. And also to know that, you know, different countries have different differences in capacity as well in terms of putting enough controls to make sure that, you know, these profit-oriented entities do not take advantage of the desperate situation that people find themselves in. And it's important to know that for somebody in Africa, the experience with globalization has always left it on the receiving end. So actually, if you are hesitant in Ireland, you can imagine that the hesitancy is even more in our part of the world, because if it is something that is seen as coming from many people who mean well, but probably those that really want to maximize the profit. If you look at the history of a place such as Africa over the last 500 years, and I know that Ireland has a bit of it, I think, from its own experience with its own neighborhoods as well. So it does build, and this thing fits. But we need stronger global solidarity. This is why conversations such as these ones are important, to bring voices from different perspectives. Most importantly, to enhance transparency, and also make sure that, you know, our governments are working more intentionally together to be able to make sure that actually what is motivating everyone is to save humanity, not to maximize profit.
Right. Right. And Peter, just on that note, you know, if you were speaking to a leader today, and we may be speaking to some, you know, I think all of us are leaders actually. So I'd say, as you're speaking to all of the leaders who are here and who will watch this, you know, what would be your message for them?
First of all, I think it is important to know that there are different types of leaders. So I think that what I would say would depend on the leader that I lead.
Well, let's go for the politicians. So let's go for.
I think I would categorize them into also geography and the type of country they lead. If, for example, I met a G7 leader, whether that is President Macron or Prime Minister Boris Johnson or even Joe Biden, the new guy, then I would probably tell him, and as I said, it is most likely to be a him for the rest of the world, I think, for the time being. I would say that it is reasonable and legitimate to prioritize vaccines for your own citizens, but it is actually futile if we leave out millions or even billions of humanity, because the virus doesn't require visas to travel, as we now know, and it will likely, the longer we let it evolve around in any part of the world, it's likely to mutate, as Aisling was saying, in such a way that it will come back with a vengeance. I think that's important to know. So moreover, it will actually draw back the progress on global economy, which I think we need to recover. It's already, you know, manifesting with a lot of inequalities, which I think was even the situation before the pandemic. The second thing is that if they really truly believe in protection of human rights, I think this is the moment of truth. They have to demonstrate that commitment, not by charity, as I have said, but by supporting, I think, the proposals such as South Africa and India have made for temporary waiver of these trips and the suspension of patents, which, as I said, is provided for in the WTO. So it's unfortunate that quite a number of these countries who have the means have actually blocked and made it impossible for that proposal to come through. So I would say, please, that is something that needs to be done. Yeah. Now, it's important to know that there's also responsibility for some of the leaders in my part of the world, in Kenya or in Uganda. So they must not miss the opportunity or the lesson of this crisis. And I think that there are many things. There's always something good also, if you are careful, to learn from a crisis. Because the decades of underinvestment in public health, the decades of corruption, no investment in social protection, is something that is also important, and that they need to work together to improve on governance and also connect their efforts as countries with similar challenges to build that solidarity and build more preparedness, especially in the area of public health, and look at it as a rights issue. Because there will be many pandemics, whether of this kind, as we know, the world is changing, climate change is there. There will be a lot of disasters of this kind. So it's important that we use the lead times to prepare well, to secure resources of a country, and most importantly, to also invest in research and technology collectively, and actually work towards strengthening global solidarity and aggregating their voice in a way that makes sense, I think, in the global space.
Yeah. Peter, thank you. Your message is coming across loud and clear. I really hear solidarity coming out in everything that you're saying. So let's leave it there. I'm not going to come back to you. I'm going to kind of come across now from Kenya, Uganda, and back home here to Ireland, to Fiona, who interestingly has had the experience of working very much in Africa and sub-Saharan Africa, and also here in Ireland. Fiona, just more recently in terms of SafetyNet, how have you guys been able to respond to COVID in general? And also, what are you seeing in terms of inequity and in relation to vaccines in the marginalised groups that you're working with here in Ireland? And you're muted at the moment. Just muted. I love that. Just wait. There you go. You're good. You have a voice.
Yes,
you have a platform.
Thanks a million, Nadine. First of all, I'll just explain briefly what SafetyNet is and what we do. So SafetyNet is a medical charity here in Ireland, providing healthcare to homeless people, vulnerable migrants, and basically those who don't have access to mainstream services. We employ doctors and nurses, admin and support staff, and provide clinics in homeless hostels, assessments for migrants, vulnerable migrants, and help with them integrating care into the mainstream. And we do outreach in a mobile consultation room in a van to rough sleepers. So we're very much, our aim is to guard against inequity by ensuring access for people from marginalised in society. And this is parallels, I think, with potential vaccine inequities, which we'll come to in a bit. I've found, and I think we all know, that when crisis hits, the poor, the disadvantaged, the marginalised fare worse. And during the pandemic in Ireland, we saw as well what Peter says, how inequity was revealed, and really how the social determinants really influence health everywhere. And people living and working in poor environments and are unable to protect themselves when they don't have access to safe own-door accommodation. I mean, it's very, very clear and simple what the treatment or the prevention without a vaccine for this virus is, and it's safe spaces in which you can be apart from other people. And that's just not the case in accommodations where we put our homeless, our people in direct provision, and people living in overcrowded, rented poor accommodations, traveller families living on unauthorised halting sites, lots and lots of people who are vulnerable in society not being able to protect themselves. So our COVID response focused on quick detection. As Mike Ryan says, we have got to act fast and get ahead of this virus, and move fast and have no regrets. So we focused on quick detection, rapid response, We set up a helpline for people in these vulnerable groups, mobile testing, and partnered with MSF Ireland to provide rapid testing analysis when lab capacity became an issue. And we developed very much hand in hand with Public Health, HSE, a cluster response which aimed to quash the outbreaks when they appeared, and they did appear in congregating settings. To date, I think we've conducted 125 sweeps in congregated settings, tested over 7,500 people, and detected about 600 people who are positive, and then tried to provide wraparound service and isolate them, etc. But it was stark to see, while conducting these sweeps, to see, for example, 50% of people living in traveller families and a halting site being positive, and not difficult to see why, with people living on top of one another in small mobiles, with lack of basic facilities like water and electricity, and things that you don't expect us to find in Ireland. So inequity in health also meant that people who did get the virus because of poor health, underlying conditions, fared worse also. And there's, I have a number of examples of, how some people really had poor outcomes. I remember one lady my age from the Roma community who our doctor and nurse went out to visit, and because she wouldn't go to hospital, fear and mistrust of the system, and her oxygen levels were so low, she actually died. They got her into hospital, but she died not long after. So, inequity and the consequence of it alive and well in Ireland, unfortunately. But the bespoke approaches that we did establish with partners here and with the HSE worked in preventing the spread quickly.
Yeah, I mean, it's just listening to the inequities that you're describing. It's it's just hard. It's hard to believe that these inequities are right here on our doorstep, and I think that's why COVID has shone a light on inequity everywhere. It's like it's gone to the cracks of inequity in every country, and as Peter was saying, and you also alluded to, Fiona, it's building on inequity that's already there. And I guess a question for you, Fiona, would be, some of the factors that you've already seen that have led to, inequity around health service, around COVID itself. How, do you see them also leading to vaccine inequity as we now are kind of rolling out the vaccine? What does that look like?
Yeah, well, nationally, and your speakers are speaking more from the point of view of globally, but there are the barriers to healthcare access here for vulnerable groups. Vulnerable groups have competing priorities other than health, other than COVID. They're trying to survive. That's a barrier. They have largely no say in health system design, which is designed for the middle classes, so may not be appropriate to their needs. And there's low levels of trust with authorities, as I've mentioned, with undocumented migrants, people who have no GP, medical card, how do they access the mainstream systems? And I think there is vaccine hesitancy, is among all groups, but definitely, misinformation from online, and when people are disconnected from mainstream information campaigns, you could see vaccine hesitancy increase. And then, of course, you've got language barriers and literacy problems. So I do think I'm hopeful, and I do think it's possible to get good coverage if we have the same kind of nuanced approaches, tailored approaches that we tackled, where we're continuing to tackle the prevent outbreaks. So if you have the same kind of nuanced approaches, I think coverage could be good. There's a paper, I think I've just shared it, by Dr. Margaret Fitzgerald at the HSC Social Inclusion, which really, it looks at how to include the marginalised in our vaccine rollout. And it's very good, and comes up with some very good suggestions, including the fact that, like, we're doing it by age at the moment, but travellers, homeless, age differently. You know, they have shorter life expectancies and have significant, you know, health problems at lower ages. So that doesn't necessarily, you know, include people, you know, who age earlier. But however, I think it's important not to get caught up with prioritizing different groups too much, because if we get everybody vaccinated quickly, then priority becomes less important. But I think it's you know, for once, I mean, Peter talked about charity, but you know, doing the right thing isn't charity here. It's actually a selfish act. So, you know, it makes perfect sense, selfish sense now to look after each other. And when it comes to getting out of this pandemic, as we can't get out of it without everybody getting out of it quickly and equitably.
Yeah, powerful words there, Fiona, absolutely. And that kind of echoing Mike Ryan, he's like, nobody is safe until we're all safe. And actually, it's always been like that with all sorts of global health issues. It's just that COVID, because it's affected everybody everywhere, has made that, has really brought that to the forefront. I might just come across to Breda in concern, and then we'll circle back around. Breda, you know, concern in terms of its response, and we've had concern with us in this, you know, in many different fora. You've been responding, you know, since the moment COVID was an issue. You know, how is concern responding, and what are some of the ways that you're supporting this whole you know, equitable access campaign?
Thanks, Nadine, and it's a privilege to follow Ashling, Peter and Fiona from their perspectives. I'm speaking as a nurse midwife practitioner side, and in mind the frontline field health workers who've been facing this from the beginning with their ongoing jobs, routine vaccinations of children, the BCG, the TPT, diphtheria, whooping cough, polio, measles, tetanus toxoid for women. So this is another vaccination program that's beginning, as Peter said, only really very briefly beginning in the countries where concern is working. And we're working basically through all our sector programs, but particularly through our health programs, working on both the demand side for uptake of services, including vaccination, and on the supply side of health services. I have a few slides here. You asked me to share you know, what concern was doing and how we're responding. Let me see if I can share the screen. There's only, oh yeah, here it is. It's mostly pictures, but we did some research. Slideshow. Oh, how do I slideshow from the beginning? Put myself down here. So basically, well, we're looking at the global situation, and in terms of thinking of Africa particularly, as Peter is here from Kenya, I mean, we have noticed in concern, fortunately so far, that the top of Africa and the bottom of Africa have been most impacted. Sub-Saharan Africa, for some reason, fortunately, until now, has not been as seriously impacted as the bottom or top of Africa or the rest of the world. But in terms of health service delivery on the supply side, we've seen that ordinary vaccination coverage is down. Many staff have stayed at home during the lockdowns, were not encouraged to leave their urban areas, and the health workers just not going to the job, especially during the restricted lockdowns. It's easing a little bit now, but it's still not back to normal. We've almost lost a year in normal health service delivery. On the demand side, uptake, as Fiona said, is also down in Africa, where concern is working. For ordinary EPI essential vaccinations, people say, oh, I fear I'd catch COVID. I don't want to go to the health center. They'll only go as a last option when they're very sick. Then we've had the same things as we saw in Ireland in the early days, disruption in the supply chains, essential medicines and health products, shortages on the protective personal equipment, and issues of quantity and quality of PPE imported into countries. Concern with our Alliance 2015 partners, you see the logo there at the top. the report is at the bottom, but we're an 8-member organization with different organizations in Europe, including Deutsche Hungerhilfe in Germany, HIVUS in the Netherlands, and others. We simultaneously undertook surveys in 23 countries between October and November last year, almost 14,000 interviews completed on sectors of education, health, and livelihoods, but I'm just presenting here 3 slides on the health side. And the big takeaways were that over 1/3 of respondents consider that their health and well-being has gotten worse when compared to pre-COVID 2019. Over 35% of respondents report having delayed, skipped, or been unable to complete healthcare service needs since the start of COVID. And 25% of respondents reported that they would not feel comfortable taking a sick member of their household to a health facility. This could be a mother with a sick child, a father with a sick sibling or child, or a person living with HIV, which we've been reported afraid to go to take their antiretroviral medication, essential to keep them alive in the early days. In terms of details, in terms of people who skip services, interestingly, again, generally the carers at home, we all know if somebody is sick, it's often the mother takes care of the sick child. Women in urban areas were particularly affected, almost 43% delaying, skipping, or unable to complete healthcare visits. Over 60% said again, the fear of contracting COVID, especially in the early days when people knew it was airborne, but were not quite sure about the details of transmission. The fear of contracting COVID was particularly high among both men and women in rural settings, although with more open ventilation, people just stayed out of the urban areas and stayed away from the health center if they could. Even in Rohingya camp and Tigray, Sudan, Ethiopia responses, people said there was a long waiting time to get the services because of the mask wearing, the physical distancing, the hand hygiene. Basically, getting services took a lot longer. And it was interesting that the biggest impact was in the urban areas, more for females in urban, rural, peri-urban, and in the camp settings. In terms of taking a sick person in the household, generally a child, the same issue, urban areas reluctance was particularly high, fear of contracting COVID, and in all contexts, women express greater reluctance. Again, women are usually the ones bringing a sick child with possible malaria, fever, diarrhea, infectious diseases to a health facility. So we see, looking at the slides in terms of health, about 1/3 down in terms of delivery of health services and about 1/3 down in terms of uptake of services. And generally it's the extreme poor population the concern works with that have travel costs, etc., have been not going to the services. In terms of concern, we immediately thought we need to protect ourselves, our staff, our partner staff, our Ministry of Health staff we work with. So we developed various briefs on the do's and don'ts, IPC PPE, particularly on staff safety, looking at different scenarios, practicing them, and following the ever-changing WHO interim guidance that was being uploaded and still is almost every day in French for our Francophone countries and with webinars for our field staff. And in all countries, just like in Ireland when I'm here, we work with Ministry of Health directives, in-country partners, WHO, UNICEF, who usually are the ones leading in terms of ordinary vaccination, delivery, and service uptake, and with the health clusters in country. In terms of our work, everything changed at the beginning of 2020. Everything, every single program. My 2 trips that were due back to Sudan and Bangladesh were stopped in February. In agreement with the donors, we had to develop business continuity plans with budget adjustments in all countries to reduce transmission risk, protect our staff, partner staff, extreme poor target population. And in some countries, we had specific COVID funded projects, like in Sierra Leone, a concern-led intervention with Goal and Trocra, Irish Aid funded, thankfully, allowed us to support half of the country in terms of the COVID-19 response. And my colleague Francis was coordinating that up until the end of last year. Almost every country in Malawi, we contributed to the COVID concern strategy and the government strategy in terms of the national response. The emergency response in Ethiopia, precautions one must take visiting the health centers, that's in French, obviously, in Chad. Concern Bangladesh, business continuity plans agreed with all our donors, Irish Aid, EU, DFID, FCDO. Concern Kenya, Peter, likewise, especially in the urban areas with our extreme poor population, and in Somalia with the Canadian application for maternal, child health, sexual reproductive health services. How to protect the staff and the people delivering the services not to contract COVID-19. Proofing everything we do with technical assistance delivered virtually. The World Health Organization obviously was, I'm sure some of you have been on them, the weekly cluster calls. We were asked to submit some photographs. By chance, I submitted 6 and 2 were selected for uploading on the World Health Organization cluster website. The first one on the left there is in the Central Africa Republic, distant teaching, RCCE, remote communication and community engagement, particularly important going out into communities and doing that, keeping the distance, doing no harm. We do not want to bring COVID-19 in. That's our biggest fear. In Bangladesh, we went the whole way with actually supporting the testing. And if you want to look at the rest of the pictures, they're at that link. This is the last slide, I think. Yeah. You know, to do no harm. The main thing we get asked is to re-establish and support the maintenance of the regular health services, especially EPI vaccination, safe delivery, antenatal care, postnatal care, the fever, diarrhea, respiratory infections, HIV testing treatments. Continue, especially with the health and the community health system strengthening efforts towards universal health coverage and SDG delivery. And now, increasingly, supporting the COVID-19 vaccine rollout within the national EPI program. We're advocating with countries to import vaccines that do not require the ultra cold chain, the regular cold chain used for the EPI program, as directed by the Ministry of Health, and targeting especially the at-risk and vulnerable extreme poor and frontline health workers. And they're the main people we want to work with and reach out to in all our work in the field. We need to listen to the frontline health workers to see where they're at, where they're going, what are their fears. If they don't feel protected, I mean, it's a very close encounter to deliver an injectable vaccine, unlike polio, which, you know, you actually don't have to touch the child. So there are real practical issues on the ground that are facing our frontline health staff with the Ministry of Health staff.
Yeah, thank you, Breda. Thank you for that, and thank you for placing, you know, vaccines in the context of, you know, the wider programming and the health consequences of COVID. So I think that's really, really clear. I just wonder, you know, in terms of I see there's a question from Paula there about, you know, just to your point, Breda, about, you know, why some African countries have been badly affected and why some have not. It seems strange, interesting that higher income places have been so badly hit. For instance, South Africa in comparison to its neighbours. So I just think that's, you know, it's just something that we're all wondering. Peter, I wonder from your perspective, any thoughts on that?
Yeah, thanks very much, Breda. Thanks, Nadine. Maybe let me contextualize that the perception, I think, because sometimes it can be misleading. It is true that maybe South Africa, of course, is more connected to the global economy, movement in vehicles, the connectedness. When the country is a bit more globally connected, there's a tendency that, you know, I'm not an epidemiologist, but I think what I need to do is to relate it to what I see every day. Because over December, over the Christmas season, I traveled to Kampala. It was during elections, moving around, and I was using, you know, cabs, private cabs to chase a few errands before I would come back to Nairobi in order to go for Christmas. People were dealing with practical issues. And I do remember one of the drivers saying, you know, we have bigger problems. Just COVID is just one of them. we have issues, we have governance issues, we have corruption, we have problems. And anyway, I contracted COVID during that period. I came back. I was just lucky that the last test showed that I was negative before I could come back to Nairobi, because at that time there were not enough ICU beds in Kampala. And just for the Christmas period, over the Christmas, my symptoms intensified and required that I had to be taken in to the hospital in Nairobi. Luckily, I was lucky to be able to access that, and I do have some insurance cover. The bill itself, I think, was, by the time I got out, it was close to $20,000 US. Now, in order to save me, now that is a figure that is unimaginable, particularly in a country where public health is private. If you need health, you have to pay for it. And of course, we know the poverty that is there. But the bottom line is that the impact of this COVID, even in what you call the Africa between Kalahari and Sahara, the impact is not just medical. It's much more than that. It has impacted on livelihoods, on food systems, on maternal health, domestic violence, care work. All these things are huge. But during that time when I was in the hospital, it took me about, I think, 17 days in the hospital because I needed some oxygen supplements. Just in my area in eastern part of Uganda, within those days, I got reports of 6 people who had died of COVID, some of them relatives. I know that at the moment, even in a country like Kenya, the positivity rate has gone, the national average is now 17%. In some cases, it is 25% as of 2 days ago. So we know that this pandemic is mutating, but it is difficult to get statistics from this part of the world, because if I have to go to test, I have to pay a couple of dollars. I have to choose whether to buy food for my children or to go and test. So you can't actually trust some of the statistics that is coming. Mm-hmm. What we know is that the governance, the steps, the lockdowns, the closing of civic space, and the excuse governments have used, I mean, it has manifested into other pandemics of different circumstances. This is why it is most urgent that this vaccine is brought under control, because as it mutates, yes, it will come back, including to Europe. If we don't, it will come back with a vengeance. But it is good to contextualize that the impact is much more in some of these areas than even, because if a government cannot meet the date, a small shock means far more to a poor person than in Europe. For us, our colleagues were saying at least they had what they call what? Fall off? Was it called fall off? I mean, those are things that are not possible here. So if you lose a job, you work for a day to eat for a day. Yeah. You don't, you die because of no food. There are a lot of things. So the impact is much more. And I wanted to make sure that that is clear. That whereas the epidemiological statistics may look that it's relevant, so the impact is much more in some of these contexts because of weak public health systems and of course the chronic inequalities that have been built over the centuries.
Yeah, points made very, very well, Peter. Thank you for that. I wonder, Ashling, just some thoughts from your perspective, and knowing that you have, you've been very involved in the vaccine inequity discussion and other discussions, other inequity debates over the years. Just some comments from yourself, some thoughts.
Yeah, so I think there is, it really is a global crisis that we're facing, as the other panelists have also identified. And I think it's the important point is, as Peter said, sometimes the statistics might seem to, and sometimes these statistics are the facts that maybe some people suggest there isn't as much in a particular region. Sometimes that can be used as a way to justify inaction, and that is completely appalling, because we know, first of all, as Peter just said, the statistics are not always accurate for many of the reasons just outlined. But on top of that, because we know that these issues can have a much greater effect in populations where there's already existing need and there's already issues arising. And I think this is another crisis, and I think we have an opportunity, I suppose, as a global society to come together. And I think pharmaceutical companies, and some of them already have, but more should take that opportunity to say, well, actually, this is a global crisis. We have to come together. It's in everybody's interests to address this. The way in which we can address it is by scaling up manufacturing. It's simple as that. We need to share intellectual property data, know-how, knowledge to do that. In some cases under CTAP, there could be compensation involved for that. So it's not, you know, this is a mechanism that we could agree on. In other cases, if we can't agree on it, we're going to have some sort of mandatory change to facilitate this. And what I would say, and I suppose the one thing that I think we need to emphasize is we can't replace or replicate mistakes of the past. Like there's been other crises where we've seen instances, particularly in the HIV/AIDS crisis, where there were drugs available, they weren't provided fast enough. And I think, unfortunately, I would very much hope that we don't make those mistakes here again. And the other thing, I suppose, it's not just social justice, as I've said, it's also in all our interests. And I think the sooner that everybody realizes that, including people, you know, everywhere, but also including pharmaceutical companies, it's in their interest too. They all have families, they're all working, they've done fantastic work in delivering these vaccines and actually producing. Scientists have done amazing work. And it's wonderful that we have that achievement. And I think it's now time to share it and time to have access.
Yeah, thank you, Ashling. And Ashling, if people are listening and they want to get involved with access to medicines or take some action, is there somewhere they can go to do that?
Yeah, so I think everybody's voice is really important in this. I really think that this is an opportunity for global change. People, I think, could look at www.accesstomedicines.ie. That's our website. All the resources are there. We're also on Access to Medicines is also on Twitter. You know, we've written news articles. They're also there. People could just engage with the debate. That was what I would encourage them to do. Engage with it and engage with some of, I suppose, the misinformation as well. Sometimes it's being presented in terms of effects, and also engage with the fact that it just because we may get access in Ireland, and already we see that there's issues there in terms of even our own supply, but that's really not good enough here. We need to have supply for everyone. I think the more people that can actually kind of agree with that message and push, you know, TDs and try and encourage government to support some of the campaigns, the better we are as a society. And it's just the right thing to do. Yeah,
great. Thank you, Ashling. Clear. I see just in the chat, just coming back to you, Breda, for a last word. I just see in the chat there, Ola Elian just has made that point where we see inequity again. It's like in Palestine, while the Israeli occupation has vaccinated a high percentage of its citizens, only a few number of vaccines were actually given to Palestinians. So, you know, just those kind of issues are happening in all sorts of ways in different things. Breda, any thoughts and comments from you, and even maybe just a message that you would leave everybody with, particularly as this debate about inequity is going to rage on?
Yeah, following on from what Peter there was saying, in many of the countries where concern is working the urban extreme poor and the rural poor, an important factor, and to protect us all, I think what's emerging is that, you know, greater ventilation protects. Most people we work with don't have windows, they might have a door. Ventilation is very good, and I'm not being sarcastic here. People live outdoor lives on the street almost 24/7. I think that's a factor that needs to be investigated more. We need to be a voice to support the extreme poor. In Bangladesh, for instance, the vaccination program is being rolled out, but through the internet. So we're working with our partners to support the extreme poor and frontline health workers who are barely literate to access through technology. You know, basic technology is a barrier to access COVID vaccination right now in Bangladesh. Can you imagine? So every country we need to support, and that the poorest and extreme poor and vulnerable are prioritized, because those who speak loudest will get served first.
Thank you, Breda.
The biggest inequity going forward from this, the secondary impacts, I'm seriously worried about the donor impacts for next year, the budgets for 2022. We already hear what's happening in the UK.
Yes,
you know,
we're totally spot on, Breda.
Economic shocks in terms of livelihoods, children out of school. To me, it's repeating AIDS all over again in the worst days when we didn't have
which is exactly, I think, also to Ashling's point, it's like we don't want to see that again. We know what we need to do this time. We do not want a sticky plaster measure. We want to really look at the systemic change. So thank you, Breda. Fiona, I'd love just to come back to you just for a last word. You know, just the incredible work that you and all of your team are doing. Is there anything that you would, you know, any message that you would like to leave us with, or anything people could be doing or thinking or saying that could support?
Well, I think, and again, just bringing it back to where we are at the moment, which is Ireland, where I am at the moment, I think we have learned good things from the response so far, and I think we need to reapply them with the vaccine rollout to make sure that inequities don't mean that people are left behind. And I think these are things like I've touched on, ways of speedy approaches, not being concerned who's getting vaccinated first, vaccinating people who are in high risk settings through no choice of their own in congregated settings, equitable vaccination rollout here at home, and all over the world. I think it's really, if we think about it, as I said, it's a selfish thing to do the right thing and look after each other and not start fighting about who's getting vaccines in front of one another.
Right. Thank you. Wise words, Fiona. Peter, one last word, just a one-liner. I see you said that in the chat and we'd absolutely love to hear it just before we close. Thank you.
Thanks. I think maybe the thing that I think it's important that we look at this as part of, as I said, a bigger struggle against inequality. And we should know that one of these is this issue of physical space. A lot of the developing countries are losing a lot of money through illicit financial flows. And it's important that we relate this because many countries are going to be forced to borrow and be more indebted in order to respond to the crisis. And it's important that as part of the global solidarity, countries like Ireland, the EU, and the developed countries have an important role to curb illicit financial flows. Africa is losing quite a lot, including $50 billion a year. So I thought that we need to relate this as part of the efforts to build that capacity to respond to this and future pandemics.
Thank you, Peter. And I'd love to, those last words, I think it was Ashling or somebody mentioned, this is, I think it was, might have been you, Peter, this is a moment of truth. It's a moment of truth. And that's not just for our politicians or leaders up there, out there. It's for all of us. It's a moment of truth for all of us to do the right thing, to speak the right thing, to support the right things, and to just stay connected in this kind of a solidarity as we are today. So just thank you all so much for your time and your wisdom and for contributing to help all of us as our thinking evolves on this issue. So Nora, back to you.
All right, thank you, Nadine. I actually want to say, if you found this webinar useful and have any suggestion, please take time to do the evaluation form. We'll send it in the chat there, and also when you close this webinar. And I would also like to thank all the speakers for all those wonderful insights. This is our first time to do the right thing, right? So we hope to see you again in one of our upcoming webinars. The next webinar would be on the 30th of April. So put that in your list. So hopefully we will see you there. And if you have any question after this, you can send us in info@globalhealth.ie. And thank you to everybody participating today. And if you want to have more updates about our events, please do check our website, www.globalhealth.ie, and also esther.eu. Thank you again, everyone, and hope to see you in the next webinar.
Oh, thank you, Nora, and thank you to our partners for co-hosting Access to Medicines Ireland. Wonderful work.